Mrs. Smith, 56-year-old accountant from Minneapolis, had a remote history of breast cancer. And by remote, I mean 15 years ago. And her evaluations were like a well baby checkup. Patient comes back with her marvelously supportive husband, who provided financial support for gaming institutions, casinos. And the patient said, gee, my neck has been troubling me. Did not sound worrisome, but the tip-off is that it occurred at night. So we don't want to ignore something like that. She also said, you know, I've lost some weight, don't have a lot of energy, indigestion. I look at her laboratory studies, her liver tests were not good. So this is shaping up as a problem. So the appropriate studies were an MRI, magnetic resonance imaging study of her neck, which is the study for bone problems, and an ultrasound examination of the liver. And as each test came back, the results were more and more dreadful. She had extensive bony metastases or spread into her spine, not only cancer in the liver, but also cancer in the adrenal glands, which sit on top of the kidneys. So I had this on the electronic record, and I knew I would be seeing the patient later that day. So patient goes into the room with her husband, and I'm mentally rehearsing how this will play out. Just like a field goal kicker mentally envisions kicking the ball, a golfer envisions how he will hit the ball. And once they see my face, it's obvious this is big trouble. So I explained to them with this sort of terminology. I'm concerned about, I'm uneasy about, I'm unsettled about some of the tests. So this is that shot across the bow. Boom. This gets them ready for what may happen. I then ask them, would you like to see the pictures? If they say yes, I can turn the monitor and show them. And when the abnormality is obvious, it's also obvious to a civilian. So I showed them the neck problems, the liver problems, the adrenal problems. And then I simply keep quiet. What most patients say, okay, what do we do now? And what we had to discuss was a biopsy to confirm our suspicions. And the question that often comes up, more often than not, okay, doc, if the biopsy shows cancer in my liver, how long will I live? And what I've learned is the following question. Why is that important to you? What are the big rocks that these patients are worried about? And equally importantly, what are you concerned about losing? What if you lost today would decrease the quality of your life? So we need to know who people are, where they're from, what they do for a living. Otherwise, we're missing a whole piece of their humanity. And there's a sense of humor in an atmosphere of tragedy. And I'm smiling because this was a loving, supportive couple. And I said to the woman, why is this important to you? She said, I want to max out all his credit cards so there's nothing left for the second wife. So there was a macabre sense of humor about this, but it overlaid, obviously, a real concern. But what I have learned is to be honest, but never to withdraw the carpet of hope. Because no matter how bad it is, none of us are prophets, and every healthcare provider has a litany of people who should have died years ago, and they come back to see us year after year. So without that kernel of hope and leaving open that window of uncertainty, people are devastated. And I can share with our colleagues out there in cyberspace, almost never will we be criticized for offering hope to that patient. But if we withdraw hope, we will be seriously criticized by that patient and that family. Now, obviously, one needs to be realistic, but in most medical circumstances, there is that element of uncertainty that we are not prophets and we need to leave that door appropriately open.